Hi friends, I am Dr Asha Baxi from Indore. A very warm welcome again to the question answer series. Today our question is to dashing Dr Seema Pandey. Dr Seema Pandey is from Azamgarh. She is member of Managing Committee of ISAR and has a keen interest in PCOS. She has many publications to her credit. So Seema, we all know that PCOS hails from adolescent to the menopause and has lots of problems. With great difficulty, these women conceive. And if they conceive, then what are the problems that they face during pregnancy?
Thank you, Asha. Polycystic ovarian syndrome pregnancies are unique in a way that there is already hyperinsulinemia, insulin resistance, a hypercoagulable state and pro-inflammatory condition. And all these things make them more prone for all those antenatal complications which are lesser in general population. To just sum up the complication, first miscarriage rate increase. That initially we used to think that it is because of hyper-LH condition. But latest studies are stating that people who are conceiving by ovulation induction with drugs or by IVF, their rates of miscarriages are at par with the general population. Second comes is multifetal gestation, and we the obstetricians are to blame somehow because the way we induce them. So we just have to be very judicious about use of our ovulation inducing agents, especially gonadotropins. And third is PIH and PET, which is 3 to 4-fold higher in pregnancies related to PCOS per se. Same is true with the gestational diabetes mellitus, which is 3 to 4-fold increase. Preterm deliveries and SGA are also at least 2-fold increase, and all these complications, if are super added with obesity and multifetal gestation, they go multiple fold, and these lead to increased rate of cesarean section, increased NICU deliveries, and increased perinatal death. So whenever a patient with polycystic ovarian syndrome comes pregnant, the first and foremost thing is to take her weight, BP and her GTT. Oral glucose tolerance test or HbA1c has to be measured very strictly and regularly, and accordingly she has to be put on insulin sensitizers. One good thing especially about metformin is whenever you are starting the metformin before pregnancy or during pregnancy, it is not going to harm the fetus, and in many studies it states that it increases the chance of term delivery and decreases the chances of cesarean section and gives increased chances of vaginal delivery. So it is your prerogative whether you want to continue it or you want to stop it at 12 weeks after your GTT becomes normal as per PCOS international guideline. BP monitoring is very important because these patients, as I told, are prone for developing PIH and PET. So strict monitoring will give a clue. And whenever you are going to do an NT scan and PFA, please do uterine artery Doppler. And if it is showing high resistance, take all the precautions as per the PIH prevention norms. And keep telling her about the diet so she doesn't increase her weight too much and that doesn't add up to the complications. And once she reaches around 30 weeks, if everything is fine, 2 doses of steroids go a long way, and that can prevent if there is premature delivery, so lung could be hastened for the maturity. And once this patient reaches the term, she has to be taken as any other term pregnancy, taking into consideration all the comorbidities she is suffering from, and accordingly you have to decide the route of delivery after counseling and consulting the couple what do they exactly want. And if we go this way along with pre-pregnancy optimization, there is no reason that PCOS pregnancy doesn't reach to a term and you get a full term smiling happy baby. Thank you so much.